Hi, my name is Alejandra Magaña, and today I'll be presenting my evidence-based practice project proposal on the prevention of ventilator-associated pneumonia, also known as VAP, in the ICU. Ventilator-associated pneumonia, or VAP, is a common and serious complication for patients who remain intubated for more than 48 hours. It increases illness, prolongs ICU stays, raises healthcare costs, and contributes to higher mortality rates. Because nurses provide most of the direct care for these patients, we play a critical role in preventing VAP through consistent use of evidence-based bundles. While the evidence supporting VAP prevention bundles is very strong, research shows that many hospitals struggle with consistent adherence. Oral care may be skipped, sedation breaks overlooked, or documentation incomplete. These practice gaps reduce the effectiveness of the interventions. The challenge isn't providing the bundle works, it's ensuring consistent application. At our facility, we see similar challenges. ICU staff have reported variation in how bundle steps are carried out, especially with oral care and sedation breaks. Chart audits confirm these inconsistencies. Our hospitals continues to experience high VAP rates, leading to longer ICU stays and higher costs. Addressing this local need supports not only patient safety, but also accreditation and performance-based reimbursement requirements. Research shows that between 10 and 20% of ventilated patients develop VAP. Each case adds tens of thousands of dollars to hospital costs, extends recovery, and impacts hospital quality ratings. Preventing these infections not only improves patient safety, but also protects healthcare organizations from financial penalties and ensures better outcomes overall. The prevention bundle includes several proven interventions, such as elevating the head of the bed, performing daily sedation breaks, checking readiness for extubation, providing oral care with antiseptic solutions, suctioning secretions, and maintaining strict hand hygiene. When applied together, these measures are much more effective than when used individually. My project focuses on 4 SMART goals. First is to apply the VAP bundle to all mechanically ventilated adult ICU patients within 3 months. Second is to achieve at least 95% compliance with all bundle elements within 6 months. Third is to reduce infection rates by at least 25% per 1,000 ventilator days. And finally, to build a sustainable system of audits and staff feedback to maintain improvements long term. To achieve these goals, nurses will receive both education and hands-on training. Checklists will be integrated into the electronic health record to track compliance. Visual reminders and easily accessible supplies will be made available. Weekly audits will measure adherence, and results will be shared with staff to encourage accountability and teamwork. The first month focuses on nurse training and collecting baseline data. By month 2 and 3, the bundle will be rolled out to all ICU ventilated patients. During months 4 through 6, we'll aim for full compliance with audits and feedback guiding progress. At the 6-month mark, we'll evaluate both clinical and process outcomes and make adjustments to sustain improvements. Clear responsibilities ensure accountability. ICU nurses will apply the bundle daily. Nurse champions and educators will guide training and support peers. The unit manager will oversee compliance and resources, while the quality improvement team collects data and runs audits. Collaboration with physicians and respiratory therapists will ensure sedation breaks and extubation readiness are addressed safely. We expect some barriers such as staff resistance, time pressures, and gaps in documentation. To address these, we'll emphasize the long-term benefits of prevention, integrate the bundle into regular workflows, and use checklists and reminders to support consistency. Recognition programs will also help build a positive culture of compliance. Evaluation will focus on both clinical and process outcomes. Clinically, we'll measure VAP rates, ventilator days, ICU length of stay, and mortality. From a process standpoint, we'll monitor compliance with each bundle step through chart audits and observations. We'll compare data 6 months before and after implementation to track improvements. We expect to see lower VAP rates, fewer ventilator days, and shorter ICU stays. These improvements will enhance patient safety and lead to cost savings for hospitals. Success in this project can also serve as a model for addressing other hospital-acquired infections like bloodstream infections using similar bundle approaches. Beyond reducing VAP, this project can serve as a model for addressing other hospital-acquired infections. It can strengthen the hospital's reputation, accreditation standing, and promote a culture of evidence-based practice. Future initiatives could expand to central line or catheter-related infection prevention using the same structured approach. In conclusion, prevention bundles are an effective and evidence-based strategy to combat VAP. Nurses are at the center of implementation, and success depends on consistent practice, education, and feedback. By reducing infections, we not only improve patient outcomes, but also strengthen the quality and efficiency of healthcare delivery. These are my references, and they were the key sources that guided my project. And that completes my presentation. I hope you enjoyed it.